Hello, everybody, and welcome. Thank you so much, Dr. Fatima Khan, for joining us today to talk about all things perimenopause, menopause, and treatments and different options. It's lovely to have you with us. I'm just going to read your bio and also acknowledge that we're both sitting on Wurundjeri country and pay my respects to elders past, present, and future, and acknowledge their non-ceded custodianship of this land. So, Dr. Fatima Khan is a highly skilled perimenopause and menopause specialist with a holistic approach to women's physical, emotional, and mental well-being. She completed her medical training at Imperial College in London, achieving a bachelor in medicine and surgery, as well as in science in pharmacology and therapeutics. Dr. Fatima has an advanced menopause certification accredited from the British Menopausal Society and Faculty of Sexual and Reproductive and Healthcare of the Royal College of Obstetricians and Gynecologists, as well as further training in the USA. So we're talking to a very qualified and skilled doctor here on all things hormones and menopause, perimenopause. And she runs a dedicated menopause clinic at Epworth Hospital, Richmond, Melbourne. She's also involved in regular teaching of university students at Melbourne Uni, as well as general practitioners in the community, which is fantastic. We're going to talk more about that later. And Dr. Fatima and her medic husband decided to emigrate to Melbourne 2.5 years ago with their daughter to experience life in one of the most livable cities in the world. So welcome, and thank you again for joining us. Our opening question that we always ask our guests is, what comes to mind, or what do you feel when you hear the phrase midlife, pleasure and power? What comes to mind?
Okay, so I'd probably just start by thanking you and your team for inviting me on your platform to share my knowledge of something I'm really passionate about. So I'm feeling very privileged to be here today. So for me, midlife is a very powerful time that every woman will experience. I think I'm so glad that you've labeled it in such a way, because the connotations we get for menopause is someone who's really timid or suffering and not relevant in society. But actually, it's the time when you are very powerful. It's a time when you're going to transition and really come into your own and discover what your true strengths are, what you really want to be doing. And it's an opportunity where you reinvent and recreate yourself. So it's quite powerful, because it's the one time where you're going to be independent and be liberated to do the things that you want to do, because you don't have those defined roles that society probably gave you as a mother, as a wife, and you have all these household duties. So this is the time where you choose on your terms how you want to lead the remaining 40, 50 years post-menopause that you have. And it's also quite a sexually liberating time for women as well, because I find that a lot of women find that they get some form of sexual awakening at this time. And it could be for multiple reasons, because of the whole transition. There is a range of fluctuation in your hormones that does give you your libido and sexual desire can vary, and you sometimes become more experimental, more brave, more confident in exploring your sexual kind of, you can call it sexual exploration. And so I think if you have the right mindset approaching midlife, it is both powerful in all aspects of your life, including your sexual life.
Yeah. Great, thank you. And perhaps to give our listeners an idea of your background, maybe could you talk a little bit about what led you to study so much around menopausal and hormonal health, and to set up, I think, the first clinic, certainly in Melbourne, which is so good to see. I know there's lots going on over in the UK, but it's just great that, yeah, there's someone like you here.
Yeah, I think it's just probably early childhood influences. My mom's one of 3 sisters. I'm one of 3 sisters. And from the time I remember, I've just heard of, either heavy periods, painful periods, pregnancies, fertilities, and all these issues. And I think the main one that really comes to mind is my aunt, who was 50, had breast cancer. And after that, my mother went through menopause and early hysterectomy and bilateral removal of her ovaries, which put her into an early menopause. And she didn't take HRT for long because she was worried about breast cancer. And then my third aunt went on to have endometrial cancer. And the irony is, none of them were actually on HRT. And so when it came to my sisters, two of my sisters have got endometriosis. I've got a bit of PCOS and also probably perimenopause. And it just became really interesting because the management is surrounds around synthetic hormones, and there's a lot of scaremongering around HRT, but not the benefits about what it gives you. And also, a woman just think it's either black or white. It's either HRT or no HRT. So I think from my personal experience, I've had to use hormones and I've had to explore that journey. And I even went to the US to study it a little bit because they're very progressive when it comes to these bioidentical hormones, which I wanted to learn about because we were so scared of synthetic hormones. And so I think that journey led me generally to study perimenopause and menopause. And although menopause on average is 51, but most women will experience the perimenopause 10 years prior to that. So if you're someone at 45 who's going to go through menopause, your symptoms will start 35. And I do see a lot of women starting in their mid to late 30s, the symptoms. So actually it's quite relevant. And I personally experienced them quite early as well. So I think it was a personal journey, and generally being in kind of a gynae women's health environment has just been kind of influenced throughout my life to the women around me.
Yeah, great. I imagine lots going on there in a house full of 3 girls.
Yes.
So what would you say is the difference? Because I know generally menopause is the word that's used, but perimenopause is, would you say it's more symptomatic than menopause, and it's more challenging for women? Because that's when all the post-menopause is, you're sort of done and dusted, but there's other stuff perhaps. But in terms of the symptoms, hot flushes, irritability, insomnia, anxiety, you know, all of those things, achy joints and things, those sorts of things really are in the I actually like to say to women, it's like you're going over a bridge, and that bridge might take a few years, and you sort of take a step back, take a step forward, and there's so many changes along the way. And also it seems to come in waves sometimes, these changes, and then it goes back to how it used to be, or a little bit. So yeah, how could you talk a bit about the difference between perimenopause and menopause, and maybe it's some of the myths around both of them as well? Although perimenopause isn't known as much, but it's becoming known, which is fantastic.
Yes, so by definition, menopause is 12 months of no periods. So, but we don't get to menopause, we don't have a regular monthly period and all of a sudden stop generally. You would have a period of fluctuating hormones. So we're going from good levels of hormones to almost no hormones. So for you to have no periods for 12 months basically means you've had very low or kind of non-existent levels of reproductive hormones, and specific estrogen, progesterone, to a certain extent testosterone. So the ovaries have packed up and there are no more hormones. Before you get to that stage, they are about someone will argue between 5 to 8 years prior to that is your perimenopause, in which you will notice in your early 40s or even late 30s, women will start noticing changes in their hormones. So what tends to happen is that your ovarian function will decline, the fertility normally will start going down, and your hormones will start fluctuating or becoming lower in quantities, which will give you symptoms most commonly in your menstrual cycle. So you might notice you used to have a monthly menstrual cycle, which will say 5 days. You might notice that's changed in its duration. So it might be shorter, 3 days, or it might be longer, 7 days. You might notice instead of being a 30-day cycle, it's gone on to 40 days. Then you might notice a change in the flow. Commonly, most women will start getting really heavy periods. They might notice they're flooding. They might notice having to change multiple sanitary napkins. And it's not uncommon for women to be in a board meeting and they realize they've flooded through a tampon, a sanitary napkin, and their underwear and their trousers. And it's quite common because they don't even know what is going on with their body. So that is a very early sign of perimenopause, the change in menstrual cycle. You might also notice then, along with that, you might start getting changes along with your physical symptoms and psychological symptoms premenstrually. So before we have a period, we have a dip in our hormones. You might notice a few days before, you might notice low mood, anxiety, irritability, along with changes in your bodily functions, such as you might get breast tenderness, fluid retention, and feel very, very fatigued and low energy. And then you'll have migraines are quite common around that time as well. And then you'll have your period, and a few days after that, you'll get an influx of estrogen and you'll feel great again. And so you might start noticing people saying, okay, for 10 days of every month, I'm getting really bad premenstrual-like symptoms, which are affecting my mood and my physical level of energy, and also along with the heavy periods or change in your cycles. And as we progress up to the menopause of lower hormones, these symptoms get exacerbated and they extend throughout the cycle. So a few years prior to your menopause, then you might start getting things like cyclical, or every other month you might get a period and you might get hot flushes, what we call vasomotor symptoms, and night sweats. They don't particularly come in the early perimenopause. For you to get your hot flushes and night sweats, you need quite low levels of estrogen. You can still have a regular period and still get night sweats and hot flushes. And that's where women get confused, because they think, oh, I haven't skipped a period. So I think the main thing I would say to women, the perimenopause is marked really by disturbance in your menstrual cycle, but also psychological symptoms of mood, anxiety, low mood, changes in your energy levels, headache, migraines. And then it starts, the more you creep up to menopause, which will be skipping your periods. And it might be 2 months, and then you might start getting periods again, and it becomes really irregular. And that's when you start noticing things like severe joint pain, dry skin, itchy skin, dry eyes. You might get hair loss, changes in general. You might notice you're getting more wrinkles in the skin. You might be losing you lose about 30% of collagen around perimenopause, menopause. So that's your entire architecture, which holds up your cheekbones and which gives it that kind of elasticity in the skin. So skin changes are common, hair changes are common, joint aches, literally affects every aspect of your body. Most women will also notice that the cholesterol might start creeping up, blood pressure will start creeping up. They might start getting weight around the midsection. We haven't even touched the vaginal urinary symptoms. You'll get vaginal dryness, and you also get changes in pH and microbiome. So you might get recurrent bladder infection, thrush, or vaginal discharge. Sexual intercourse can become painful just because there's not enough lubrication. And then, sexual functioning such as low libido is quite common as well. So estrogen receptors are found in every single body. And I think the main message is, it's not just to do with your reproductive cycle. Hormones for women have a vital role in every aspect of our brain, bone, heart, skin, you name it. That's what makes us women. So we've got to see beyond reproduction and look at it at how important it is for our overall health and well-being, having estrogen on board.
And it's also, I'm just thinking of perhaps those women who are at the very beginning of their journey, and that's a very long list, and they might be feeling, oh my goodness,
oh my God.
it's not, that's kind of like this whole smorgasbord, but it's not like all of that for every woman. I remember reading somewhere that our hormones are as individual and unique as our fingerprints and our actual makeup of them. So it's they might not experience all of those, because I don't want people to freak out.
I think the reason why we freak out is because we're like, this is the first time we're hearing about it. And I think if it was discussed, this is what happened, but actually it's just like anything else. When you're going through puberty, or when you're going through, say, infertility, if you're prepared, you know what happens. You might get them, you might not get them, but it's knowing that you don't have to suffer. Because what freaks women out is the fact that, oh my God, I have to suffer this for years. And I think the key message is that you don't have to suffer, because there's so much you can do. And the reason I think why women get scared is because they think, oh my God, there's this helplessness, where actually there isn't. If you treat it and you manage it effectively, you can go into function better than you probably did beforehand.
Yeah, and that's what I from the little I know of your work, what I really love is that you look at the holistic picture. It's not just here, take this and it's that's the happy end of it. You talk about exercise, you talk about diet, like there's almost steps that you can take, and you also offer like the whole palette of bioidenticals, and I don't know whether you do the synthetics as well, but like it's like there's a lot of different options to that women can choose, and it's just as their hormones are unique, their experience of that is very unique as well, and some will be completely overwhelmed and some might sail through and not really notice. So it's sort of like there's a very big range. But can you talk a little bit about your pillars? You call them the holistic pillars?
Yeah, so I came up with this thing on hormone wellness pillar because I kind of had to go through them myself and work on it myself, because taking hormones at any point, if you choose to do so, is really only one of 8 pillars. So it will help with your symptoms, but it's not really going to solve your problems and give you your optimal physical, emotional, and psychological health. And so the most essential one, I mean, we can go in any order, is normally their nutrition. So what we eat and how we nourish our body is very important. Movement is very important. Moving our body, however you choose to move it, we can dive into them deeper, it's important. Then stress management is very important. We live in a culture of where we kind of thrive on stress, but actually stress is the single factor that will exacerbate all your symptoms. And if you want to smooth sailing through the perimenopause and menopause, stress management, not sitting in front of Netflix and watching hours, which I do as well at times. I think we need to be very active, not passive stress management, actively involved into either you do kind of nidra yoga, or you do deep abdominal breathing, some form of reducing that sympathetic drive, which we're functioning on all day, and stimulating that parasympathetic drive, which leads me on to sleep, which is very important, because that's the other thing we do. We're all on this suffering from chronic insomnia because we only get very minimal sleep. It's disturbed sleep, which then has an impact on our mood and our appetite and our weight. So, so we've gone through nutrition, movement, stress, sleep. Then I talk about supplements as well. So I think things like magnesium and B vitamins are really important for women's hormone health, but also stress management as well. And then I add a few other things like vitamin D in it as well, and we can go through them in detail. And then I talk about social connection, because you can have, and purpose kind of goes along with that, and meaning. So you can have HRT and do all the right things in life, but if you don't have meaning, and it doesn't have to be you saving the world, if your purpose and meaning is to be around for your family, your friends and family, that's great. But you need to be living a life which is fulfilling you, because when we're in that state of unfulfillment, they drive negative emotions, and negative emotion releases cortisol and stress and leads to leaky gut, leads to chronic inflammation, and predisposes us to stress. So I think that social connection and being around your loved one is really important. And I think, and then it's HRT and hormone replacement therapy, which in my view is very important if you want to prevent against long-term chronic illnesses that women suffer as a consequence of low estrogen. So we spend about, women's life expectancy in Australia is about 85. Most women will go on to live till 90. So, you know, you've got another 40 years, if not more, post-menopause. So actually, we're not proactive at all in managing the menopause for short-term symptoms, but also it's important to have preventative intervention to manage the future risk that menopause brings to women's lives in the post-reproductive era.
Mm-hmm. And that's what I'm noticing. There's 2 main reasons for like going and they might be combined, but choosing hormone therapy, and one is the short term because of the overwhelming nature of the journey, so it's to relieve that, and then the other one is the long term preventative reasons
Yes.
for choosing that. So if because this is always a question, and I know that I've read like you can be on them forever till you die, but say you're a woman that's like, I'm not sure I want to be on them forever, I just want to get through this short term, is how does that work? Because I don't.
Yeah, so it's interesting what women say to me, I don't have any symptoms. And the reality is most women will have symptoms. What they mean is they don't have hot flushes and night sweats, which are really disturbing, because that's what we associate. But people don't think about the short-term symptoms such as cognitive function, so forgetfulness, not being able to remember things, focus, concentration, attention, confidence can go down, low motivation. And then, so if you're someone who is 49 or 50 and you are working in, say, or you're just working, it doesn't matter if you're an executive team or not, you have to work, you have to perform. And if you're in a position where you can't afford to leave your work for financial reasons, now if you're waking up every hour during the night with a hot flush, you're not going to be able to function because of lack of sleep, number one. And on top of that, the low hormones, we know estrogen is a precursor for serotonin. So when you have low levels of estrogen, you'll have low levels of serotonin, which means you'll have low mood, you'll have anxiety, then you'll also have other difficulties. It's also in charge of contributing, or as a precursor for dopamine, which is our kind of reward base. So that gets us out of bed, makes us do things, gives us the motivation. So we have low levels of brain neurotransmitters when we have low estrogen. That's where we get the psychological symptoms from. So when, you might not have hot flushes, but if you're trying to work and you can't focus, you've got low concentration, low motivation, low mood, anxiety, and you're making decisions that aren't right, that. I'll get women coming to me and saying, normally I could make these decisions and now I doubt myself. And that affects their confidence and their self-esteem. And then they will end up giving up their career or that promotion when they've actually worked 25 years to get that promotion, but they're finding they can't cope. So the psychological symptoms can take a toll if you're trying to perform in a professional environment. And then you've got the physical symptoms, such as the headaches, the migraines, the dry skin, the jointings, all of those things. And so I think it depends on what your personal preference is. And if you want to eliminate those, because the average symptoms of menopause will last 7 years. Mm-hmm. 70% of women will get menopausal symptoms. 30% of them will be the severe symptoms, okay? Now, what might be severe for you might be moderate for someone else. So it's important to realize what everyone's threshold is and what your daily life looks like, And so if your daily life looks like you got to get up and you got to have a board meeting and you're one of the only female leaders there and you're having a hot sweat every hour and you're stumbling on your words and you're stopping between lines, and then that's not going to function for her. She needs that to stop. So I think it's really important that women choose what works for them, because we're all on a different journey.
I agree.
And sometimes I think as women, we can discourage other women to take help because we're so scared. We kind of like, oh no, I wouldn't do that. So my goal is what I normally tell all my patients. There's 2 goals for managing the menopause. The short-term goal is to alleviate your symptoms, if not eliminate those symptoms, so you can function in your personal life, in your relationships, at home, with yourself, and also in your professional life. So you have quality of life, because living a life like this for 7 to 8 years it takes a toll. And I see those women every day who, a lot of them burst into tears when they come in because they've tried to do it themselves. And I think the message here is you don't have to do it yourself. There are lots of things we can help you with. And then it's also a great opportunity to address the future risk of developing osteoporosis, heart disease, and Alzheimer's. So the main cause of women's deaths, this is Australian statistics, but it kind of works towards Western countries globally, is heart disease, is a main killer of women, followed by Alzheimer's disease. The main reason women will go to a aged care facility is Alzheimer's dementia, or an osteoporotic hip fracture. So if you are walking and you trip and you break your hip, which is very common to get what we call a fragility fracture because your bones are really weak, 50% of women will not be able to go back and live independent lives. Now, these illnesses do not occur commonly before the menopause because estrogen is potent in protecting against osteoporosis, heart disease, and Alzheimer's disease. So the decline in estrogen at menopause, along with cellular aging, predisposes women to these chronic illnesses such as Alzheimer's, osteoporosis, heart disease, colorectal cancer, and depression as well. So for me, I explain to them there's no cure when you get there in your 70s when you're going to get this. It's about preventative interventions at 50. And this is why when you replace them hormone replacement therapy, give them HRT, that reduces the risk of getting, say, heart disease by 40 to 50%. The other 50% comes from your lifestyle. So what you're eating, how you're moving, smoking, alcohol, social connection, stress management. And that's why every woman I see, 50% of my talk is on HRT, the other 50 is on lifestyle and complementary therapies. And I personally believe in what I call a hybrid approach. So it's not that you do it complementary naturally only and you only do HRT. If you're going to be doing HRT alone and you're not addressing all the other environmental factors that you can modify, lifestyle factors, because we know the food, alcohol, smoking, our weight have impact on our cellular aging and predisposition to certain diseases. So it has to be a hybrid approach. And when it comes to HRT, women are scared about synthetic hormones. We now have licensed body identical hormones, which are natural estrogen and natural progesterone, and it's replacing like for like to restore the body's function, and we eliminate all symptoms. And most women will restore and feel the same that they used to feel beforehand.
Yeah. So when you say natural, I know progesterone is wild yam or Mexican yam. Estrogen, is that like a soy, like phytoestrogen, like is that from a food? Where does the natural estrogen come from?
Yeah, so I think we just need to be clear on the terminology. So the main data and all the kind of scaremongering came from the Women's Health Initiative, which was done about 19 years ago. And it was almost like $1 billion study for really women in their 60s, or their mean age was 63. And so they came with all these risk of breast cancer, clot, and we'll talk about those in a bit. But they used synthetic hormones. So they were using conjugated equine estrogens, which is from pregnant horses, kind of mare's urine. And also they use synthetic progestogens, which is medroxyprogesterone. So when the news came that this HRT combination predisposes women to getting these risks, then they started using what we call compounded bioidentical hormones. And it was a quite well marketed and used in the States. And so these products are extracted from wild yams, which are plant extracted, natural progesterone, estrogen, testosterone, and they're compounded in a pharmacy. And they started using these, and you can formulate them in a cream or a crochet or capsule. And they've used them for a few years because really the main option for women was synthetic HRT, which they didn't want to use, which is fair enough. But we do also have what we now call licensed body identical. And with that, I mean, they've got their pharmaceutical grade, so they're still plant extracted, but they're pharmaceutical grade. We've done clinical trials on women, and we've got data on safety on the lining of their womb. We know that they're being absorbed to prevent, again, osteoporosis, and we have studies on breast safety data as well. And so these products are available and prescribed by every doctor, and they are preferred over the compounded molecules. The problem with the compounded molecules is that there's a huge variation in them. So every pharmacy will produce them. So if you go to 10 different pharmacies, each pharmacy, the testosterone, say 5 milligrams, will be differently formulated and different levels will be absorbed in the same person. because it's not to a certain pharmaceutical grade. The absorption is not the same. If I gave someone ibuprofen, I know how it's going to behave because I've studied it in multiple women and I've got a fixed dose. So compounding can be unpredictable that way. The other problem with compounding is that you need regular blood test monitoring and also ultrasound monitoring as well, the lining of the womb. And commonly you will get prescribed progesterone via cream, and that does not protect against endometrial cancer. So a lot of the bad press that you might hear about bioidentical is because women have been taking estrogen and progesterone in a compounded cream, and they've then got a thickened lining of their uterus, which is endometrial, and they've ended up getting endometrial cancer. And that's why a lot of the British Menopause Society, the North American Society, and the Australian Menopause Society caution against its use, because progesterone transdermally via the skin does not protect against endometrial cancer. So it will always be given as a tablet. That's the best way to protect it.
So just to be clear, bioidentical and body identical are different, and body identical has been through the sort of pharmaceutical kind of line, whereas bioidentical is it depends on the compounding chemist.
Yes.
And that's where the unregulation comes from. And with the creams versus the tablet goes through the liver, is that right? So that's why it's more I don't get that bit. And the cream and the end of, can you explain?
Yeah, so the progesterone on its own, it's not to do with the liver or something. It's just through the skin, does not get absorbed into levels for it to protect the lining of the womb. So if we've got a uterus, when we give you estrogen, the estrogen will thicken your lining. The lining of the womb is endometrium. And we always need progesterone to oppose the effect of estrogen on the lining of the womb. Now, we know when we take an oral tablet, that protects the lining of the womb, but transdermal estrogen does not. Sorry, transdermal progesterone does not protect the lining of the womb. So the estrogen will thicken it, and then you'll get abnormal bleeding and thickening. So progesterone via the skin does not protect the lining of the womb, and women have known to get endometrial cancer. And that's why there's been this negative kind of news around the bioidentical. If you're on bioidentical, which is compounded, normally you would have a 6-monthly pelvic ultrasound to measure the lining of your womb. You also need to have blood tests to make sure you're absorbing it in a good amount. So that's a lot of monitoring to do if you're going to be on this for the rest of your life, and it's quite expensive. And so, there might be certain cases for it, but when you have something that's got the safety data on it, it's extracted from plant extract, it's natural, you've got clinical trials on safety on it, and women, that tends to be the first line, which is licensed body identical, and you don't need to do all this excessive monitoring on it.
So with the hormones, because what I know is like estrogen and progesterone are like the partners, and they're always doing this balancing act, and in that sort of perimenopause roller coaster, they kind of, progesterone goes down first, and then that's estrogen dominance, and then so with that, and with each woman being different, do you do tests and then decide, okay, I'm going to give this tiny little bit of this, because how does it, because that's in itself, the testing is a bit complicated, isn't it?
Yeah, so the difficulty with the perimenopause is, so menopause and perimenopause really is a clinical diagnosis. You can do blood tests, but then they can come back normal. And then what do you do in the perimenopause phase? So I've got women who will have an estrogen of, say, 100 in January, and in March, if they've ovulated and had a period, it will go up to 500. So it gives you a snapshot, and our hormones are fluctuating up and down every week, if not every day in our bodies. So in the perimenopause, normally if a woman presents you to over the age of 45, she's got the clinical symptoms, you give a trial of hormones. A woman who presents to you under the age of 45 is considered an early menopause. And I would do blood on her to see if she's got symptoms, just to see why she's skipping periods. Could there be something else? going on. And if a woman presents at the age of under the age of 40, then she'll have something called what we used to call premature menopause, but it's actually called premature ovarian insufficiency now. So they will definitely need investigation to exclude other causes. So if you came to me over the age of 45 with clinical symptoms, I would generally, depends if you've seen your GP or not. If you've got heavy periods, irregular period, I would do a pelvic scan because I want to make sure you haven't got fibroids, you haven't got endometrial polyp, there isn't anything abnormal going on, there aren't any ovarian cysts if you're getting any pelvic pain. So that is good practice to do that if it hasn't been done. I'll also do some bloods to check your thyroid function because they can give some symptoms similar to this, such as fatigue, hair loss, and changes in weight and periods as well. And I'll also check your hormone profile, including your follicular stimulating hormone, luteinizing hormone, estrogen, progesterone, testosterone. But you have to be mindful that these can come back normal, but it shouldn't change your treatment or management. So it's all on an individual woman's basis and what her symptom is. So every 50-year-old does not have the same management protocol. You have to listen to the woman, listen to her symptoms, and address the management protocol according to her unique symptoms. You can't just apply one size fits all when you see a woman in perimenopause and menopause. That's one thing I've learned after seeing thousands of women. They're all different. Every one of us is different.
And from what I've heard, it can be a trial and error. Like it doesn't happen immediately. There can be this sort of backwards and forwards of trying to work out the right balancing act. Yeah.
Yes.
Oh, that's my headphones.
I mean, just to add, the perimenopause is probably the most challenging because you do have hormones that are fluctuating. So some months you have very low, some months you've got really high. You'll get disturbance in your mood and PMS symptoms. And so your estrogen is going up and down like this. And the aim is to give you background estrogen to balance it, also to give you progesterone to manage your cycle and the bleeding. When you've had 12 months of no periods, actually that's easy because you've stopped producing any hormones, and we can exogenously from outside give you very balanced level of estrogen, progesterone, and testosterone, and that's very easy to manage, and you feel more balanced because there isn't that fluctuation happening anymore. So the perimenopause is more challenging to manage, and that's why the lifestyle things are really important as well along with that.
When you say you've stopped producing hormones, the adrenals, if they haven't been burnt out, they still produce estrogen, and the ovaries do a little bit. Like it doesn't complete, the body does still, if it's a healthy body, continues to produce estrogen, but just not in the way that it used to.
Yeah, so at menopause, when you're declining, say you're going through the menopause, the ovaries will be declining in the level of estrogen it produces. It does go down to very low levels and non-existent. So that is one myth that ovaries do not produce any more estrogen after the menopause.
None, like zero. Okay.
It goes to like less than 20, less than 30. You can produce, because there are no eggs, the reproductive function is essentially gone, but the transition is smoother because you will get extra, what we call gonadal, extra ovarian, or outside the ovaries, your adrenal glands will produce a little bit, but the reality is 90% of the women are burnt out. You know, an average 40-year woman's got 2-3 kids, working full time. By the time they get menopause, the adrenals are burnt out. So that reserve is a very poor reserve to help them out. Then the other reason why we accumulate fat around so the other source is fat cells. So our fat cells produce a bit of estrogen. And one of the theories is the reason why we get abdominal fat happening, or that midsection belly that you get at midlife, is twofold. Estrogen levels, when they decline, you will get reduced insulin sensitivity, which means when you're metabolizing carbohydrates, you're not very good at breaking them down and metabolizing them. That gets stored as fat around the tummy. But also the fat around the tummy is there as a protective measure to help you produce estrogen, because when your estrogen levels are going down, it's a huge stress on your other functions and organs in your body. So the brain, the heart, the bones. Women are used to, say, having 400, 500 picomoles of estrogen in their reproductive phases, so 20s, 30s, and 40s. And here we go at menopause. And if you measure them, if they've had no period for 6 months, their estrogen will be 90 or 60. That's a huge decline. And so going through the menopause is a form of stress for your body, because your body now is having to adjust to function without estrogen. So it's quite stressful on a cellular level. So one of the way it compensates is by producing estrogen and fat and adrenals. Majority of women have, I don't like the word adrenal fatigue, but what we call hypothalamic adrenal axis dysfunction. Their adrenals have packed up. And so that's why the menopausal symptoms are a lot more pronounced in some women if they've had a really busy, stressful life. But if you're someone who's normally, say, has a life where maybe you don't have a demanding job, you're very relaxed, it's very slow pace, then your adrenals might be able to compensate and support you a bit more. But in the women, obviously, that I see, it might be a skewed proportion of women. They will have more severe symptoms because they've had this, if they're career women, or even actually I get a lot of women who don't work. It's a combination because we've got stresses from other sources, relationship, partners, looking after family, children. So adrenals aren't a safe bet for the modern woman to rely on because we run out. And this myth that we produce estrogen after the ovaries, there isn't really anything. And I've measured enough estrogen in postmenopause women to know that. So there isn't really a source of estrogen from the ovaries. It declines slowly, but it does go to less than 100 picomoles for most women.
I remember reading somewhere that there's not a lot of research that's been done into the ovaries post menopause, and like if they do anything, if there's any activity there left, but that makes, from what you said, it makes me fonder of my belly fat, that the body's just doing its natural wisdom thing of actually that might make women kind of a little bit more sort of just friendly towards that it serves a function actually.
I think it's just being more kind and compassionate towards yourself. And that actually my body is changing. I think acceptance is something we haven't talked about. Accepting that we're going to go on this journey, and when you're empowered with the right knowledge, you can manage the symptoms. You don't have to suffer. There's a lot of perception around menopause as suffering because it's got a lot of negative connotations around it. And I think no, it's the other way around. And I know the symptoms can be daunting, but the reason they're daunting is because most women hear it for the first time. But if we heard it in our 20s, 30s, and 40s, knowing that this happens, okay, but you know what? There's great treatments, which we haven't even talked about at the moment. But normally, I don't know whether you want me to talk about the treatments now or what did you want to talk about, but guide me on what you want me to speak about.
I think what I'd love to talk about is, because obviously you're unusual. Yeah, there's not many doctors like you around. And from what I've heard, your average GP doesn't there's no specialist training. There's very little training for them. I know there's a bit of a movement in England actually where they're trying to get more GPs trained up, and I know that you train GPs, but so women will go with an expectation that maybe they have this knowledge when they don't. Secondly, that they might just go for, because I remember asking a GP ages ago about bio, because I'd just been reading and I was curious. I was there for something else, but I was like, I just want to see what the reaction is around, I think it was bioidenticals rather than body identicals back then. It was, I don't know, 5 years ago. And she just basically was like, no, the synthetic HRT, that's the way to go. So I feel like there's still the standard response, and this could be wrong, but I'm generalizing, but it's like either HRT with the synthetics or antidepressants. They're the two routes. Whereas how could women have a sense of agency when they go to their GP and have more of this partnership, and I suppose be educated themselves as well? So there's lots of questions in there, but yeah, that's what I'd like to talk about.
So the first thing is, in defense of GPs, I did not get taught at medical school or my clinical training, and I did obstetrics and gynecology as well for a long time, we did not have any menopause training in that.
Even in obstetrics and gynecology?
Yeah, because there's so much other things going on. You've got, there's a range of gynecological problems that you're dealing with. So it's something you might just say, okay, this is HRT, and then that's it. And you kind of didn't want to know about it because there wasn't enough education. And then even when you become a GP or doctor, there's no education around it. So you've got to realize most GPs who will do it is they would have had to have looked it up, read something about it, because they've had to do it in the interest of their patients. And so they're not really making the best, they don't have the depth of knowledge that someone like I would have, because this is all I do, or a specialist would have. So in their defense, they're just giving you the straightforward one, which is the combined or the synthetic or whatever's available. And so normally going to a GP, that's what they will give you. They'll either give you a combined synthetic tablet or a patch, which isn't bad short term, because short term, they don't really cause you that much long-term issues. Even with the synthetic combined HRT, the risk of breast cancer goes up after 5 years. Within a 5 years period, there isn't an increase in breast cancer, but it gives you other kind of side effects from the synthetic hormones, which we don't want. So that's the first thing. And the second thing is, my whole approach is to educate women rather than medical professionals, because I feel just like any other medical illness or any part of your life, when you want to pursue a career, whatever you want to do with your life, you are making an informed decision based on the knowledge you have gathered through your research. And so my vision is that women are aware of all their options, hormonal, non-hormonal, complementary and natural treatments. And then they go to the GP and they say to them, this is what I would like to try. Are you able to support me on my journey? And so it's a shared decision that you're both going on and undertaking, rather than it being a doctor-centered saying, oh, can you please help me? The doctor gives you a prescription and you leave. And you're feeling still quite vulnerable and disempowered because you're scared and you don't know what's happening. So if you're aware of the risks and the benefits of each option, how to manage your menopause, and it's important to be proactive about the management, wherever your route you choose, then you will feel more comfortable going to a doctor. So you need to do a bit of prep work going to see your doctor, because when you go, you are more knowledgeable. And I get a lot of patients who say, I looked at your Instagram, there was lots of information. I went to my GP and my GP gave it to me. And the GPs will then be encouraged to look up that information as well, because they'll be like, oh, this is great. I've learned something new as well. So it's about educating women, and women taking ownership and responsibility for their own health, not being scared, going to the right science-based, evidence-based information websites, and then saying, okay, I'm fully informed. I want to try this treatment option, and I'm going to go to my doctor. And you may come to a shared decision management option, rather than it being a doctor-centered, which I see a lot of the time, and women are really unhappy with that decision. And important that you're not unhappy. It has to be something that you want to do, not the doctors asking you to do.
Yeah. And that's so refreshing to hear that shared decision making, because I think that's something that is a paradigm shift. Just like talking about menopause and perimenopause, that's a paradigm shift. We're making it less taboo. The other thing is to really sort of change this idea of going to the doctor and they're the guru and they know about your body better than you know. Like it's a partnership. Like they obviously have expertise and have studied and know heaps, but it's like it's still your body. So there's that sense of self-responsibility, I think, is a really, and also the education side of it. Traditionally, we have come from this, mostly women will learn at school or through magazines. I mean, now the internet, there's so much available that we can get our hands on, but and it was always couched in reproductive terms rather than what actually happens after that. So it's again raising the value of, there is value after that. You're not just, your reproductive abilities. It's like there is a whole nother life chapter or season ahead of you. And I'm just going to quote, actually, because you said, with the correct mindset, midlife can be a time to recreate, reinvent, and reconnect to our true purpose, which can be liberating. So, can you say a little bit about that? Because you'd see so many women, and that in this chapter of their lives, and culturally, certainly in the West, it's not a particularly valued one yet. Like, I think it's changing. But can you say something more about that?
Yeah, I mean, I see women when they present to me really rock bottom, and a lot of them will just burst into tears. And so that's very disheartening for me to see someone who is feeling so vulnerable and desperate that they've suffered so much in silence, and that they feel like they can't go to anyone. And but then it's also really powerful, the transformation they'll get once I've seen them and helped them navigate this. And by 4 to 6 months, most women will say, I have never felt this good. Because not only will they say they feel like themselves, but they feel better. Because it's not just feeling like yourself, but it's also feeling like you almost have this awakening and found this true purpose of what you're really going to do for the rest of your life. Because the kids have gone, and some of them might be single, and then I'll see them and they'll be like, oh, I found a new relationship and I've got a new job, and they're taking those bold steps that they might be scared to beforehand. And they're different women. They're the same woman, but more powerful, more independent, more liberated, much more confident. I love that transformation, because the estrogen really does give you that bit of boost in your confidence. Actually, most women have this confidence within them. It's just the transition over the few years has they've got a lot of self-doubt and low self-esteem, and low motivation kicks in. And we might have gone through a divorce or a difficult relationship, lost a parent, and there's lots of these life events happen where you're just being knocked down and you just think, okay, everything around me isn't going right. Is this what life is? There's a element of hopelessness, and then all of a sudden they'll navigate. And a lot of it's mindset training as well. And I think if you can give that woman that hope and vision that they can achieve and do whatever they want on their terms, and HRT just eliminates, my aim is to eliminate all your symptoms so you feel your best physically, emotionally, psychologically, means you can do anything you want to do on your terms. And I see women like that every day, every week. And so I have the most rewarding job, because I know women go on to lead amazing lives. And so it's transformative when you see someone who can help you navigate these things. They feel better than they have done before. And I don't know, I think you have to, I wish I could record their testimonies and then play and encourage other women. I mean, I don't, because of patient confidentiality, but that quotation is because I've witnessed that from thousands of women.
Mm. And from what I know, like, because like you said, you'll be seeing like that portion of women that are so overwhelmed, and it's just such a showstopper for them. And to help them through must be incredibly rewarding to the other side. And for me, working with the women, I've obviously see like a different, well, I don't know, I see such a range of women, and each women's choice is so valuable to themselves because it's where they're at. But it feels to me like there's like, before perimenopause, you're on one side of this kind of canyon, and then the bridge is perimenopause, and that's the tricky stuff with the roller coaster opportunities, as well as, there's dips, but it's doing all the work. Like, it's doing the work from all of those pillars that you talk about: the physical, the emotional, and making choices, because actually we're preparing not just our bodies for that other landmass on the other side of the bridge. We're preparing for the rest of our lives. And there's a lot of like shedding to do emotionally. Like, a lot of grief can come up, and anger, and all
Yes.
this sort of emotion. And it's almost like we have to recalibrate or sort out, if we're talking a filing cabinet, it's throw a few of the old files away, and just sort of set everything in order to prepare for this next phase, which can be incredibly powerful. Yeah.
Yeah, and I also find the fluctuating hormones, we know, as I said, have an impact on your brain neurotransmitters. And I think they re-trigger some of the old traumas as well. Could be relationship, could be childhood. And so a lot of women can then start being quite unkind to themselves and feeling quite negative about their bodies, but about themselves, and have regrets. And I think that's where the mindset shift is important, not how you perceive the menopause, but also letting go, forgiveness,
Mm,
acceptance. If you've, if you've gone through a difficult relationship, let it go, accept, forgive where you are. Things happen because the way they were meant to. And if you've made mistakes, they're not, I mean, I don't really believe in mistakes, because I think we all have errors of judgments and we need to be more forgiving. And as long as we learn from those, because they're lessons.
yeah.
So errors of judgment, no one is going to go and make a decision that's going to be deliberately harming themselves, which
Yeah.
is what a mistake can be. And then we can say, oh, I'm so stupid, I can't believe I did that. But actually, it's not. I would just say it's an error of judgment, which in hindsight is very easy to say you made that. But at that point in time, you made the decision that you thought was the right one for that moment. And you did something that you thought was the best interest for you, but it wasn't. So let's learn from that. What have you learned and how can you move on from that, rather than, the language is really important. And especially for women, there's so much of guilt and everything we do. And of course, a man can make the same mistake or error and he won't even think he's made a mistake. He's like, oh, okay, that was a bad decision, move on. As far as we might cling on to it and then have all these associations with about our self-esteem and self-worth from it. So mindset is really important, but acceptance, forgiving, letting go is really, really important, because you can't go into you can't be liberated in life if you are in prison from in your past, essentially.
Yeah. And when you say about letting go, like it brings to my mind that autumn, like I love referring to like post menopause as the autumn in a woman's life, because there's, it's the wisdom, there's a harvest, but it's also, there's a lot of letting go to get there. And I always think of the trees and all the colors in the leaves, and that's also quite the emotional colors that arise in us, and the histories that we have. It's a bit of a reckoning, really, where we get to kind of see our past but also see the future, like we're at this
Yeah.
kind of, and I think also because our own mortality, we are closer to death than our early years. There's that realization there's not a lot of time left, and what's really important, where's the value for me now in what I want to give to the world. And yeah, so where can people find you if they want to know more about you? You mentioned your Instagram. Could you please, say the name and anything else where
So
they can get hold of you?
I mean, so I consult at Epworth Hospital, and it's called the Agora Specialist Clinic. So you can find me there if you just Google my name or Google menopause specialist. And then I also do educational social media content. So it's mainly there to give you evidence-based information, give you all your options. I think that's the main thing. And that's on Instagram under the handle of menopause specialist. I'm not as active because I try and manage it myself. I don't have anyone doing it professionally, but it has all the relevant information on your management, but also in weight management, stress, my hormone pillars, and I do a lot of Instagram lives with. I love holistic care, so I love doing Instagram lives with either naturopaths, acupuncturists, herbalists. These are all very potent complementary interventions, even if you are taking HRT or not. It's the only issue is the sustainability of it long term, because they can end up being quite expensive. But I think when you bring in all these complementary aspects from all these wonderful natural therapies, that's when you really see your body balance out and you see great benefits. So although I'm medical, I'm very much in line with all forms of complementary therapies to get the best version of you.
And I really love that you're on a mission to educate women, because I think that's the first step in really being more empowered in our
Yes.
choices that we make around our bodies. So thank you so much for joining us today. It's been such a pleasure to hear your knowledge.
Thank you. I feel like there's so much more that we could talk about. But
Yeah,
uh,
I know. Well, we'll have to have you back. We'll have
yeah,
to
I
have you
know.
back.
But there's lots of information around. Thank you for having me again, Charlotte. I hope your um, audience and followers and all the lovely women that you'll be helping out find this useful.
Thank you. Thank you so much.